Hello guys, good evening. Today we are going to discuss about Polycythemia Vera. So let's continue. Polycythemia Vera means increased bone marrow production of red cells, granulocytes and platelets. Okay, by the word polycythemia only we will understand that there is increase in the cell count. So here myelocytes are increasing, so it is panmyelosis and polycythemia which is responsible for most of the symptoms. Okay. It should be differentiated from relative polycythemia, okay, which that relative polycythemia due to the hemoconcentration and other causes anamata. Okay. Pathogenesis activating mutations in JAK2 tyrosine kinase pathway. So there is a decreased requirement of erythropoietin and other hematopoietic growth factors. JAK2 involves in the JAK-STAT pathway. It causes downstream of multiple hematopoietic growth factor receptors, so including the erythropoietin receptor. There is a decrease in the erythropoietin receptors, so there is decreased production of erythropoietin. And JAK-STAT pathway, which is active, then red cell members are abnormally high. Okay, now this JAK-STAT pathway, which is active due to the several mutations in the JAK2, and now red cell members also very abnormally high. So erythropoietin levels are obviously low. There are more red cells. What is the need of erythropoiesis then? So erythropoietin production in the JJ cells will be less. And JAK-STAT pathway, obviously there is decrease in the erythropoietin receptors, so erythropoietin level will be low. The elevated hematocrit means packet cell volume, okay, or a number of RBCs per unit volume of blood, which leads to increased blood viscosity, and there is a sludging, okay, sludging between these RBCs. And together with thrombocytosis and abnormal platelets, they make patients with polycythemia vera prone to both thrombosis and bleeding. Okay, greater than 97% mutations in the JAK2. How this mutation is occurring? Valine is substituted with phenylalanine, okay, at 617th residue in JAK2. So the mutated forms of JAK2 found in the polycythemia vera like this is associated with marrow fibrosis. This fibrin deposits in the bone marrow is seen. Okay, in 25 to 30% cases, the tumor cells contain two mutated copies of JAK2, a genotype associated with higher WBC counts. In 25 to 30 cases, what will happen? This tumor cells will contain both the alleles are mutated, like two mutated copies of JAK2, a genotype which is associated with increased WBC counts, means you will see leukemia in those members, and splenomegaly is seen. Okay, why splenomegaly? These RBCs are very high in number. They will get rapidly destroyed after their lifespan of 120 days, and they will get destroyed in that spleen, okay, which is a graveyard of RBC. Obviously it should enlarge because it should accommodate large number of destroyed RBCs, right? So there is splenomegaly, and symptomatic pruritus is there, means pus accumulation will be there, and a greater rate of progression to the spent phase will occur. Okay, let's continue this. And proliferative drive in the polycythemia vera and other myeloproliferative neoplasms associated with the JAK2 mutations, which is less than the chronic myeloid leukemia. Okay, what are those? Marrow hypercellularity, leukocytosis, splenomegaly. Okay, JAK2 signals are quantitatively weaker and qualitatively different from those that is produced by BCR ABL mutations. Okay, what is a morphology? How they look? Okay, in marrow cell count will be high, right? So marrow will be if you do marrow aspiration and if you study, we will get hypercellularity in that marrow. Okay, there are more cells seen in the marrow, some residual fat which is usually present, and increase in the red cell progenitors, usually accompanied by increase in the granulocytic precursors and megakaryocytes. Megakaryocytes, they will form the platelets, right, as well. And Moderate to marked increase in the reticular fibers is seen in 10% of marrows. As we discussed before, marrow fibrosis is seen. So these reticular fibers are deposited in the marrow, leading to the marked increase in the fibrosis, okay, in the marrow. Mild organomegaly, as we saw, splenomegaly is there, and mild, okay. Early in course, largely by congestion at this stage, as we saw in hemodynamics about congestion. In this congestion, we will see heart failure cells also, okay. And at this stage, extramedullary hematopoiesis, which is minimal, okay. And peripheral blood contains increased number of basophils. We saw before also granulocytes number will be increased, so especially basophils are increased, and abnormally large platelets we saw here, megakaryocytes will be increased, and they increased in the size also, so large platelets are observed in the peripheral blood, okay. And polycythemia vera, it before we saw spent phase. After that, extensive marrow fibrosis we will see, and which displays the hematopoietic cells. Increased extramedullary hematopoiesis in the spleen and liver, okay. Extramedullary hematopoiesis which is seen. Normally, medulla only contains a large amount of blood vessels and everything, and hematopoiesis usually occurs in the medulla, but here extramedullary hematopoiesis is also seen. So, organomegaly will certainly will occur, and transformation into acute myeloid leukemia as WBCs are increasing. It and myeloid cells, myeloid progenitors increasing, it may land up into acute myeloid leukemia. Typical features occur in 1% patients, okay. So how we will find, we will identify the patient is suffering with polycythemia vera. What are these are laboratory investigations, right? So what means peripheral smear, these are this morphology. Beside this, what are the clinical features we will see in those members? Normal, from first onwards, if we come, incidence is 1 to 3 in per 1 lakh individuals per year, okay. Appears insidious onset, usually in the adults of late middle age, okay. Most symptoms are related to the increased red cell mass, and hematocrit also will be increased, okay. There is also increased in the total blood volume. These factors cause abnormal blood flow, particularly on the low pressure venous side of circulation. Yes, right, arterial pressure will be very high than venous pressure, so they are saying low pressure venous side, okay, in the circulation, and becomes greatly distended. These veins will become greatly distended, and patients are plethoric. Plethorhia means like somewhat bluish discoloration at the lower and upper eyelids, and we will see like that plethorhia, like, and cyanosis, bluish discoloration of mucous membranes and skin we will see, and due to the stagnation and stagnation of the deoxygenation blood in the peripheral vessels, okay. If deoxygenated blood stagnate only, we will observe cyanosis. If there is oxygenated blood, we don't observe that bluish discoloration. Plethorhia, cyanosis won't be observed, okay, won't be appreciable. But here in the peripheral vessels, deoxygenation of the blood is getting stagnated there. There is a large pooling of deoxygenated blood. So we are seeing this cyanosis and plethorhia, and headache, obviously, dizziness, hypertension, as there is increase in all the cells, and GI symptoms are common. Like GI symptoms means normally nausea, vomiting, these are common. Intense pruritus, before also we discussed pruritus, okay, pus, and peptic ulceration may occur, okay, resulting from the release of histamine from basophils. Why this all occurring means, basophils we saw in the peripheral blood, we will see in the morphology. There is increased basophils and large megakaryocytes, like large platelets will be observed. So from this increased basophils, what will be releasing? Histamine. So this histamine will release, and it will cause the above mentioned dizziness, hypertension, GI symptoms, pruritus, peptic ulceration, etc. Okay. High turnover gives rise to hyperuricemia symptomatic. gout, etc., which is seen in 5 to 10% of cases. Abnormal blood flow and platelet function, which accompany the polycythemia vera, which leads to increased risk of major bleeding and thrombosis. Okay, there is abnormal blood flow, like turbulent blood flow, which is abnormal. Like platelet function is also abnormal now. So these are occurring in the polycythemia vera. Why this is occurring? Due to the increased bleeding. No, okay, increased risk means it will lead to increased risk of bleeding and thrombotic episodes. Okay, thrombus will be forming more. In 25% of patients, patient will present with DVT, MI and stroke. Thrombosis also occurs in the hepatic veins, producing Budd-Chiari syndrome, and the portal and mesenteric veins leads to bowel infarction. So these are severe dangerous complications, like DVT is dangerous. And okay, we should use warfarin to cure this DVT. Okay, we'll use warfarin. So, and mesenteric veins leads to bowel infection and minor hemorrhages like epistaxis in the little's area, or Kieselbach's plexus. We'll see this epistaxis, and bleeding gums will be seen, which are most common, and life-threatening hemorrhages in 5 to 10% cases. Hemoglobin concentration if greater than 16 grams per dl, and hematocrit will be greater than 55% or more. Okay. Chronic bleeding leads to iron deficiency, can suppress the erythropoiesis. Okay. WBC usual WBC range is 4,000 to 11,000, but here it is increased, as we saw before, as it is polycythemia and acute myeloid leukemia in some cases. So there is an increase in the WBC, which is usually from 12,000 to 50,000 cells per mm³ we will observe in the polycythemia patient. And platelet count, which is greater than 5 lakh platelets per mm³. Without treatment, death from the bleeding or thrombosis, so occurs in months of diagnosis. What is the treatment? Phlebotomy. Phlebotomy means we will cut that vein and we will remove this excess amount of these cells, and we will again, or we'll remove this thrombus, and we will again infuse the fluid. And JAK2 inhibitors we will use. Okay. Normally in the patient with splenomegaly only we will use these JAK2 inhibitors. They are not effective in other cases. Okay. Most crucial one is phlebotomy only. Polycythemia vera tends to evolve, and it may go into spent phase, during which clinical and anatomical features of myelofibrosis will develop. Okay, it undergoes transition in about 15 to 20% cases. In average period 10 years. Okay. Appearance of obliterative fibrosis in the bone marrow and extensive extramedullary hematopoiesis. Okay, before only we discussed spleen, liver. Okay, and principally in the spleen enlarges greatly. 2% of patients polycythemia vera will end up into acute myeloid leukemia, which is dangerous. Okay. Acute myeloid leukemia clone lacks JAK2 mutations. JAK2 mutations occur in the abnormal stem cells. Okay. Here they are saying acute myeloid leukemia, normally it will lack JAK2 mutations, but these JAK2 mutations will occur in the abnormal stem cells, already harbors others oncogenic mutations, leading to risk of giving rise to several different myeloid tumors. Unlike chronic myeloid leukemia, transformation of acute lymphoid leukemia, which is rarely observed, and consistent with the cell of origin being a progenitor committed to the myeloid differentiation. Okay guys, this is all about Polycythemia Vera. I hope you enjoyed this video and obtained some knowledge about Polycythemia Vera. Okay, as well. Okay, guys. Thank you for listening to me carefully, and so thank you. Thank you. Thank you, guys. Thank you.